Dr. Colorus, is your you attend the exam and they have excision of the nevus? I think you or not?
Yes.
Yes. Okay. All right. So shall we start, Dr. Farouk, or still early?
Yes. No, you can start. Please go ahead.
Okay. All right. So you see my screen now?
Yes, we can see your screen.
Okay. I start by Dr. Colorus session. Okay. So if you see here, this is the scenario: is you have a 20 years old woman in the day case for excision of skin nevus under local anesthesia. Your consultant has prepared the skin, give local anesthesia, only to be called for different theater for emergency operation. You are being asked to excise a lesion. This is scenario you have something like this, Dr. Kororos. Just tell me what happened in the station. What you how you start. After that, I tell you what is supposed to be.
I will make a remark the nevus like crescent shape around it, one
Yes.
centimeter above and 1 centimeter below it. After
Okay.
this, I will incision around this mark, and
Yes.
I will undermine the skin. After
Okay.
this, I
So
will
till now, I will tell the detail after that. So till now, you missed one mark. You know what is this one mark you missed?
wear gloves.
No, of course, wear gloves. All this is not forget it. We don't expect it anyone forget to wear gloves. We speak about the technique. This is patient before you make a marking, no problem. You start incision, but you need to test is this patient is feel the anesthesia as work or not. You do that.
No, I didn't do this.
Okay, so this is one mark gun because before you make incision in local anesthesia, you need to test first the patient is the anesthesia is working or not. Anesthesia usually work after 5 minutes, but sometimes may be delay, maybe not enough. So this is the first mark you lost. Can you tell me what happened after that?
Okay, I will test anesthesia by any tool. After this, I will.
No. But those, no, just tell what happened in your station, what you will did.
Okay, after I undermined the skin, I cut
Yes.
the two boundaries of nevus. I excision it
Yes.
with blade, and I put the nevus on the specimen for pathology.
Mm-hmm.
And after this, I take suture by.
Okay. So we stop here also. In this specimen container for the specimen, you write the patient names or any detail of a patient or put a sticker for the patient or not?
The assistant examiner, he told me, consider my hand is this container, but I didn't write any name or something like this.
Okay. So you made this station. This is step also because of course, in any sending specimen, you need to label the specimen just to avoid mismatching of the specimen. After that, what you did?
I take suture. I suture this cut wound in patient's eye, and the
Yes.
patient asked me maybe 3 or 4 questions about if she can take a shower, if any water can come on this area.
So what is your answer?
I said no water on this area for until you cut this suture and healed.
Okay, so all right. Okay, so in your practice, doctor, if the patient asks you, "Can I take a shower?" What is your answer?
I said you can take a shower. Yes.
Okay, so why in exam you say don't take a shower?
I read it on book for MRCS. No shower for
Okay,
few
so
days.
it is important to know, Dr. Corollos. Okay, if you something is not do in your practice, don't do it in exam. Okay, all right. After that, what you did?
I take suture, but it was loose because when I take first suture, it will cut and not the edge is cut because
After that, what
plastic.
you did?
I take it again, but I didn't make it tight. I make it loose suture.
Okay. No problem. No problem. What else?
I take 3 suture. After this, I finish the station.
Okay. All right. So after you do that, you clean the wound and cover the wound or not?
No, I didn't clean the wound and cover them.
Okay. So don't clean the cover. You give an instruction to the patient when and where he will remove the stitch or not?
No, I didn't do this.
Okay. You tell the patient about the complication of the wound, like wound infection, bleeding, or something like that or not?
No.
Okay. So I will tell you what is your mistake. So just for teaching purpose. So first you need to test the sensation. I will explain this, and after that I tell you at the end. So we start first. So this is a scenario. You see the scenario. This is a sample in exam. Usually it is a tissue. This is expensive, by the way, and you have a mark. You see it. It started first. I will speak about lidocaine after that. So as a procedure first, you need to pick the selection of the instrument in the container or kidney dish. So you take needle holder, you take non-toothed, you take toothed, you take scissor. Of course, we have adhesive dressing. Of course, you choose a suture must be cutting needles 2-0 or 3-0, something like this. After that, it is important the examiner notice that you hold the needle in the outer third. Of course, you don't hold the needle by your hand. You use non-toothed forceps, and the foreskin use toothed forceps. After that, what you will do, make an incision, ellipse incision, usually half centimeter, because this is nevus, not a cancer. Half centimeter is okay. So just a small ellipse. Sometimes maybe less. Of course, the first step, first mark is check the skin is anesthetized, so use tooth forceps before beginning, so to confirm that the patient have no sensation. After that, you make excised, and when you make excise, you need to put in the container, and in this container, you put a label. You have a sticker beside you. In this sticker, they write the name of patient, like mentioned in the scenario, Mr. X or Mr. Limb, and they put a sticker or ask the assistant to put a sticker and open the container and put inside the container. We don't have any material or any solution. We put it. Of course, we don't use formalin because formalin is used in museum, not for histopathology. But usually either you use nothing or use saline. After that, explain the patient what is the operative care. Post-operative care, you can take a shower, yes. And in some country, like in Southeast Asia, we use a spray called OSCE spray. OSCE means operation site spray. Maybe I put the picture later. So this is a spray, make a coating layer, so the patient can allow to take a shower, but not allowed to go to swimming pool or piscine. But the patient can take a shower. Okay, this is not take a shower is an old policy. I think it is in the era of my father, not our generation. They have the old generations of surgeons, they tell the patient don't put water because the water is not clean. And this is the old theory, maybe before 1960. When can suture come out? So you remove the stitch, usually in nearby clinic or nearby GP clinic. And usually it is after 1 week or 10 days maximum. You have any complication, if you have infection or fever or discharge or bleeding, come to the hospital or emergency department at any time, day and night, evening, weekend. If not, you can follow up you in outpatient clinic after 10 days or 7 days to see the result of histopathology. Okay. After that, in some hospital, you give instruction to the patient, or you give the patient pamphlet or something like this. Okay, so back again to Dr. Michael. Okay, so in your station, I tell you what is the missed mark. You miss it. the first mark first,
Yes.
you need to test for the sensation by tools the forceps. You need to test for the sensations, and usually you test by something like tools the forceps. Second, it is important to put it in the sample. You can put it at the end because you make a suture and all this. You can put it inside, but after you finish, because of the gloves and the sterilization, supposed to be sterile or clean, so you can put in container, and this container have a sticker or something. Usually, in each patient have a sticker like his name. Second, you need to clean the wound and cover the wound. We don't leave the wound exposed. Okay. I will ask about the chat because I have many suture technique here. So I give you about antibiotic. This is clean wound, so don't give antibiotic. After that, you need to cover the wound, and this is missed by many students all over the world. After that, you need to give an instruction to the patient when and where he removes the stitch. So 1 week, 2 weeks, whatever you need, and leave it in the GB clinic. And he need to come again to see the result of the histopathology. And it is important also to know any complication can happen. That's it. Okay. I think this is the typical happened in this scenario. The student usually miss to give instruction to the patient. Okay. I think someone add something in the chat. I ask about antibiotic prophylaxis daily dressing over the wound. This is accepted. You mean you need my answer? So this is clean wound, so don't need antibiotic prophylaxis. Antibiotic prophylaxis not in this clean wound. No need. Daily dressing, of course, no need, of course, for daily dressing. Because if wound infection happened, usually happened after 5 days, not the first day, not second day, not third day. This is what you need to ask. Is Dr. Omar, Muhammad Omar, this is your answer? What you need to ask? You ask about this or something else?
Yes, he asked about the antibiotic prophylaxis, and if it is a clean wound, commonly
Yeah, clean wound, no need.
No need,
no
yes.
need, except if you put prosthesis or something.
Yeah,
Okay.
and some candidate will say, I will follow the antibiotic protocol of the trust I'm working at. It's also accepted, but we usually
Okay.
don't
All
like
right.
them to say they will give antibiotic because this is a clean wound and this will cause super infection.
Okay. The second, and usually the common question we ask you, because we don't ask you to give antibiotic, we ask you what is the dose of antibiotic you give. So we ask Dr. Corollos again, what is the dose of antibiotic you need to give, usually?
Antibiotic?
No antibiotic, local anesthesia.
Okay, it's depend on type of anesthesia, if it's lignocaine or bupivacaine or.
Okay, first don't give option, because if you give option, I ask for the two. So don't dig yourself into option. So speak about xylocaine. What is the dose of xylocaine?
I will calculate the maximum dose. It will be
what is the dose?
It depends with adrenaline or not adrenaline.
Oh, again, you put your okay. So, Dr. Corollos, is your policy? It is the easy way to fail an exam. We don't give us option. When I ask you what is the dose of antibiotic of the xylocaine or lignocaine, okay, I use usually xylocaine, plain xylocaine, so it is 3 to 5 milligram per kilogram body weight. Suppose this patient is 70.
Usually, Professor Sherene, when they don't know the answers, they want to go to some another area, which with adrenaline or without adrenaline. But it's a good advice because this question they commonly fail. What is the dose? How many mil you need to inject? So this is very important.
It's very common.
Corollos, yes.
We put this question maybe more than 10 years. Still, the answer is not correct.
And they still fail in this simple question.
Yeah, so you have you see here, so it is 3 milli per kilogram body weight, 3 to 5. So if the patient is 70, so I give him 200 in 2%, it is 10 cc. Just remember, this container is beside you. You can see the bottles is beside you, and is written here 200 milli per 10 milli. So in exam, if you are a good observer, it is easy to pass. Okay. But if you tell me back again to you, you said So you give
Yes.
the dose 3 to 5 milligram. What about if it is, you said it is xylocaine with adrenaline. So what is the dose?
It will be 10 centimeters, the maximum dose I can give.
No, it is 5 to 7 milligram per kilogram body weight. Must be per kilogram body weight. So even 10 can be somewhat high. What is the contraindication? Don't give xylocaine with adrenaline.
طلع في ماليزيا في بالك
If the patient have
طلع ماليزيا على الهواء
No. It is in the digit, in the toes, and in the penis. Okay? So we repeat this again because the second scenario is the same. Okay? So we start again. I start by this because you have this situation. So it starts by suturing in general. Okay? With you also still Corollo, suturing of wound, which is a common station. 26 years old man has got wound in the right side. Again, we make it right side to be accessible. The nurse cleans the wound, give analgesia, inject local anesthesia, do 3 interrupted suture. Examiner ask you some question. So the first again is ask about the dose. I will ask you again, what is the dose of local xylocaine? What is the dose?
It will be 5 millimeter per kilogram.
3 to 5 milliliter per kilogram body weight. So what percentage of xylocaine you used? Usually 2%. If you use 2%, what is 1 milli of 2% contain how many milligram? 1 cc of 2% contain how many milligram?
1 milli cc how contain milligram, it will be
in 2%. Okay. So again, as you see, 2%, 1 mil equal 20 milligram. So the maximum for 70 kilo is 10 milli. If you give with adrenaline, 5 to 7. What is the contraindication? Contraindicated in penis, so no circumcision with local anesthesia, ENT, fingers, and toes. And this is a picture of the gangrenous tip of penis of the patient take local anesthesia with xylocaine, adrenaline, which is contraindicated, and the same also for diathermy. Okay? So back to the wound again. What instruction you need to ask the patient about in this type of wound? What instruction, what you need to tell the patient to ask the patient about before you start?
After suturing, he should take...
No, forget suture. I just explained to you. Technique of suture maybe have less mark because maybe you are expert. Dr. Mariam is new graduated. So we don't looking for your technique of suture. We're looking for instruction. So this is inside lacerated wound, and usually it is due to knife. So what else and or occur in the backyard of the house, in the countryside? So what else you need to ask the patient? What else you need to give to the patient apart from antibiotic?
If he has any allergy against xylocaine, or if he has
no, it is no allergic to xylocaine. What else?
If he has
any lacerated wound occurring countryside, you are in rural area or valley and have lacerated wound, what you need
tetanus,
to do to the tetanus. Okay, so don't forget in this scenario in particular, we mentioned about you need to give the patient anti-tetanic prophylaxis. So how to ask the patient about anti-tetanic prophylaxis? What you tell him? What you need to ask? I tell you the answer. Suppose I am the patient. What you need to ask me about?
How old are you? Did you
no, not how old are you? I am 50 years old. So what else you need to ask?
Did you vaccinated while childhood with tetanus vaccination?
Yes, but it is 20 years ago or 30 years ago. But what is the correct question? Anyone?
Do you have any card for of vaccination?
Okay, doctor.
When was your last tetanus?
All right, so this is the correct answer. Where is the last time of vaccination? So last time of vaccination is within 5 years, 2 years, 3 years, okay. If more than 5 years, I give the patient booster dose. Okay, so what is the last time of vaccination? If more than 5 years, give the patient booster dose. So usually in some country, they give during childhood, like diphtheria, pertussis, tetanus, and in some countries they give when you enter the army. I think in your country, Carlos, we don't have vaccination card, or you have now?
No, actually, we don't have vaccination.
Okay, in England also they don't have vaccination card for tetanus. So I don't know other part of the world. So you ask about tetanus, and after that, it is important if more than 5 years, so it is better to give the patient anti-tetanic prophylaxis. After that, of course, introduce yourself. Don't forget to test the sensation, prepare the instrument, choose the proper needle and suture, do suture, cut the thread, clean the wound, cover the wound. What is missed by all the students? 3. They miss to clean the wound, to cover the wound. So this is gone. They forget to test the sensation before he start incision or suturing, and he missed this mark. So we have 3 mark already lost. 1 for test sensation before you start. 2nd, clean the wound, cover the wound. And for my experience, I found no one of the students covers the wound. I don't know why. Okay. After that, this is the suture, usually interrupted suture, and in one side. And the space between the first and second equal second and third. This is one of the students. It is a gift from Prof. Yushak, is a famous surgeon in Malaysia, and he say this is wrong. What is wrong from your side? What is the wrong as you see?
It's under tension.
Under tension first, second?
The knot is on the edge of the wound.
Yes, the knots must be lateral, right side or left side like this. So this is have the knots in the middle, which is wrong, under tension, which is wrong. Okay? Of course, as I mentioned, it is lacerated wound, so give patient antibiotic. Antibiotic can be ampicillin, can be fluoxacillin, can be anything. After that, instruction to the patient, where and when remove the stitch, missed by many students, complication of the wound, contact number for the hospital, all these missed by many students. So, when and where remove the stitch, 7-10 days in GB clinic, complication of wound like wound, infection, bleeding, and pain, contact number for surgical department. Okay, so again, suture come in many situations. Either do a suture, either lacerated wound and trimming the edge and make a suture, or either excise the nevus. Okay, I think we still have some suture. So this is, after that we have the station of the nevus, we discuss it, and again we ask you in all station about you choose, and usually choose which needle you choose in the exam, by the way. Which needle you choose?
Cutting needle.
Cutting needle. And what suture?
Simple interrupted suture.
No. What is material, like absorbable, non-absorbable?
I will choose Brolin.
Brolin. So it is absorbable suture. Okay, so use whatever you use, but must be absorbable is written. And of course, it is important if you forget the dose, it is written here. 200 milligram is 10 cc or 10 milli. It is the dose for 70 adults, 70 kilo. It's very important, very common, and missed by many students. Of course, to open this, you need to ask the assistant to open the suture for you, or you can open before you wear the gloves. Okay? And of course, hold the needle in the tip, like here, to hold the needle in the tip, lateral third. I think I have like this, and just the tip. And if you need to redirect it or to adjust it by non-tools, not by tools forceps. Okay. Of course, this is cutting needle, this is round needle, and this is the label for all this. Of course, before you start, it is better to see expired date. Can be expired, no problem, and you have toothed and non-toothed. And again, you tested by toothed forceps. Okay. Don't forget to put in the container. All right. The next station is the same also. It is wound debridement. Wound debridement. So we have can either simple cut wound, lacerated wound, nevus. Okay. So if you have a wound, 35 years old man, lacerated wound in the thigh, you will be manage this wound. So Dr. Corollos again. So how to manage this patient?
Yes. Okay,
How to manage?
after I will test the sensation after I give xylocaine
Of course,
to
this
the
patient is cleaned and give local anesthesia, so it is okay. So you test
I will
the
test
sensation.
sensation with toothed forceps. After this,
After
I will
that,
show. I will ask the assistant to give me the suture, and I will take the Vicryl to 0 on the side, and I
is
will
the
take
Vicryl is
the
absorbable or non-absorbable?
absorbable.
So why use absorbable?
Because
It can use, but not ideal. You can use it, but it's not ideal. Why? How to for the skin use absorbable or non-absorbable suture?
non-absorbable.
Okay, so usually use non-absorbable. In surgery, in general surgery, if you don't know which stitch you use Vicryl because Vicryl can stay 6 weeks or 3 months, so it take a time. But the ideal is non-absorbable suture like Borine or Circle Isilor. And of course the cutting needle. So no need to take Vicryl. By the way, Vicryl, what you use in your country is not Vicryl, it is coated Vicryl. So it is treated like single layer, not braided, although it is braided. After that, what cutting needle, use non-absorbable suture. What else?
I will ask the patient when's the last time you take vaccine.
Okay, so it is 1 year ago because I joined the army, so no need to give him booster dose. After that,
I will give him a warning sign if he have bleeding, he have infection.
No, this is at the end. This is at the end. What is the technique now? You need to make it.
Now I will make simple interrupted suture, 3 suture.
No, it is lacerated. Lacerated means irregular.
Okay, I will
I
cut
have
the
a
wound.
picture. What you make?
Debridement to this lacerated and make it cut
How
wound.
to make debridement?
I will cut the edge until it makes
How to cut the
alignment.
edge? How to cut it?
With
what
blade,
instrument you used?
I use toothed forceps and blade.
Okay,
and
so you
this,
can use toothed forceps and scissor or knife, no problem. Okay, after that you make suturing or you make interrupted suture. After that, after you finish, what you will do?
I will clean the wound and I will make
cleaning by what?
Chlorhexidine or alcohol.
Chlorhexidine or betadine or alcohol can, but okay. After that?
And after that, I will put dressing and give the patient the warning sign and contact number.
What mean by warning sign? What do you mean by warning sign?
Any pus, any infection, any inflammation in the
wound.
wound.
So just tell him, I tell the patient about complication, just to make it simple.
Yes.
So I speak to the patient about complication like wound infection, bleeding, and any discharge. After that, you clean. So what is the instruction you give to the patient?
The instruction, you should take antibiotic. It's depend on his age. If he is adult, he will give 1 gram.
Dr. Corollos, don't say option. Don't say depend on age or because next question expected from examiner. Suppose it is young age. What is the dose you give to him? If I ask you in the exam, suppose this patient is 3 years old. What is the dose of antibiotic to give to him? What is suppose your answer?
I will give. I don't know in pediatric dose, but I think it's
so.
5
But you tell according the patient age. You open the door for that. So it is important. It is easy in OSCE to fail because you fail yourself. But I think anyone knows what is the proper answer you say if you ask you about the dose and they don't know the dose. What is the proper answer? if you don't know the dose.
I will make consultation for pediatric.
No.
According to the trust policy.
Can, but what happened in practice usually? Suppose you are in ward round in your hospital and we have this situation. What you do?
I search for it.
Okay, where you search?
BNF.
Okay, either any application. So I check in Google or BNF or any drug index according to your country. So it is usually the correct answer. In Southeast Asia, we don't ask about doses. But the student knows that I check it in my mobile application because all doctors have mobile application for that. Okay, so you give antibiotic. What else? Usually penicillin group, and what else?
Make dressing day by day, and he should go after 7 to 10 days to outpatient clinic to remove the suture.
Yes. Okay, and tell him about complication. All right.
Yes.
Good. So any question so far? So is that important? Forget the technique you make
Yes,
suture.
one
Yes,
question.
Mariam. Yes.
So, when the question scenario is given, are they going to be present in the case as a case of like this is a wound debridement or just the scenario itself?
No. They have a case. They usually have a plastic. We have this something like this. It is what is called rubber, and this is rubber. What we will do, we use it, and you trimming the edge, but it is usually in the thigh of the real patient, real person. Usually one of our students.
Okay, and also you had one laceration question scenario and one wound debridement scenario, right?
No, it is the same.
answer-
Lacerated and wound debridement is the same.
Okay, so we don't need to separately say to do the thorough washing of the wound with NS and everything in the suturing station, right? Do we need to
No,
mention
sometimes
that?
in some centers, but not in. They put some sand and foreign body inside the what's called the sample, and you
Okay.
need to remove the stone or remove the foreign body or wood or something. But it's not in our exam.
All right. Okay.
I think you can attend the exam. I think you are in UKM now.
Yes.
So we have exam next coming 2 weeks with Edinburgh. You can help in preparation. You can see the station.
All right, Prof.
In United
All right.
Kingdom, they always get an actor and they tie around the thigh the plastic specimen.
Usually all over the world
Yes,
it is the
and
same.
they usually make it wear a gown, and there is a bracelet with the name. So usually the patient, the candidate need to check is the correct patient. So he need to look at the arm bracelet with the name of the patient, and he need to check also the consent form. You need ask it to, can I see the consent form for this procedure? We usually print out the consent form. They need to check it as well.
Okay.
And it's very important to show your professionalism, the way your body language, how introduce yourself, how confident you are. And there is a lot of things which have removed lately. No need to inject local anesthesia, it's already been injected. And they done a lot of modification to make this station to be much simpler. This is my experience from UK station.
But usually most of the students failed in this station because majority don't know the dose of the European and how to manage and all this. And no one, I was last time in India, no one speak about tetanus prophylaxis. Especially when we mention he's in backyard or village or rural area. So it means that he needs.
It's very important as well that you are showing Dr. Korollos the style of the exam. If you've been asked the question, don't dig to yourself to have another question. How much age? It's a lot better to say, I don't know the answer. Can we come to this question later on? This is not a problem. It's quite accepted. But you need to be straightforward to the question as much as possible. And this is the OSCE style, which a lot of candidates are missing. Direct reply to the question. If you don't know, say I don't know. It's much better than wrong answer or deviate to another question, which Professor Sherene told you, okay, what if it is 3 years age? You don't know the pediatric dose. So you are as if you are digging yourself the hole, and the hole is getting bigger. Yeah. That's a very good Prof.
Yeah.
Sherene.
By the way, thank you, Dr. Muhammad. By the way, all of the students have the same background and the same experience. But usually, if you go to in more detail, it is easy to fail. Okay. I just review other stations that can come in exam. So we have deep knots. Deep knots usually we have this sequence. They have a cup and they have this C shape, and this is magnetic. So if you pull it up, they up with you. So it's come up with you. So you need to be gentle. You need to use your finger, like as you see here. So push by your finger. Any type of tie is accepted. By needle holder is accepted. By your hand is accepted. So it is just deep knots. Of course, it is better use non-absorbable suture, better to be silk because it's strong. Of course, choose suture without needle. Use your hand or needle holder. Use your index as you see here. Okay, this is maybe have a station because we have a station, have this and have how to make it shape for secure bleeding. Also in the rubber tissue or rubber area. Okay. We have also abscess drainage. How to drain an abscess. So we have this sample, and usually we put inside, we put gloves, and inside the gloves we put toothpaste, and to ask you, doctor, how can drainage an abscess? Any volunteer or Corollos, still up to you. How to drain an abscess.
Do you like to jump in, Dr. Abdurrahman? Oh, okay, go
Okay,
ahead.
I have got this station in my exam.
Okay, good. So what is your approach?
First, I got a consent from the patient.
Okay.
I told him what will I do.
Okay.
Then I started to anesthetize the wound. It wasn't anesthetized.
Local anesthesia.
Yes.
In your practice, in your country, you use local anesthesia to drain an abscess?
No.
Okay. So it is correct or wrong?
It's correct to be given at the edges and in the dermal layer.
All right. If you have abscess in fingers, I agree you can make ring. But if you have an abscess in the thigh, we don't accept it to give local anesthesia because local anesthesia not work in the area of the bus because of the pH.
Okay.
But no problem. What else?
I started to make the incision.
Incision. So what is the direction of incision? It is in the thigh. I think it is the thigh. What is the direction?
Yes. I made it longitudinal.
Okay. So it is correct longitudinal. Why correct? Although it is not follow the line of Langerhans.
That as this would be trimmed after that. It will
no, just a minute, you don't answer my question. Usually the thigh, in the thigh, that
yes,
the
I understand
line.
that. I was asked this question and I told him the wrong answer, that I had to open it as Langer's lines, but I was afraid to tell him that it will be laid open and healed by secondary intention, and there will be
no. We don't ask you like this. Usually, if you open an incision in the thigh, you put it oblique because of Langerhans line.
Yes.
Okay. Yes. But in this abscess in the thigh, I prefer to be longitudinal. Why?
For me, I prefer to be longitudinal. At my hand, it will be.
No, we don't care about you, Dr. Abdurrahman. We don't design surgery according to your belief.
This wound will lead open and will heal by fibrosis. So
no. We have nothing like this. This is what we call it is very strange. It's not accepted. You know, we have a rule. We have a basic surgical rule. If you open the abscess in the thigh, better to be longitudinal, although it is against Langerhans line. Anyone knows the answer?
Is it because the same direction of fibers as the muscles and then contraction will cause?
No,
closure
what else?
of the cavity.
Because we have
Avoid-
important structure longitudinal. What is
to
this
avoid
important
tetanus.
structure?
Oh, okay. The femoral vessel.
Femoral.
Tetanus vein. To avoid tetanus.
All right. Long saphenous can be secure, but usually we make it longitudinal. After that, what you will do?
Is it the answer or something else?
Say again.
Is
You
the
hear me
saphenous
or not?
the saphenous is the answer or not?
No femoral. Femoral artery is longitudinal.
But it's too deep for an
Yes,
abscess.
but usually it is a fixed rule in surgery. If you make an abscess in the thigh, you make it longitudinal. Usually
Okay.
of the avoid injury of blood vessels. Okay.
Okay.
What else? What
Okay.
you'll do else?
Then I drained the abscess and started
How to drain the abscess? Drain it. After
I
that,
started by pressure and then I put a gauze in the abscess on my finger and opened the reculi in the abscess.
okay.
Okay. Then I irrigated it.
Yeah. So one by one, what use for irrigation?
Normal saline.
Normal saline. Okay. What else you need to use for irrigation if available?
I might use a chlorhexidine.
Okay, or hydrogen peroxide. Okay, no
Oh, hydrogen
problem.
peroxide.
What else? What else you missed now?
In this step,
You make a drainage. After that, what else?
after that, I didn't finish. After that, after irrigation, I would put a gauze, alginated gauze.
Alginated
Okay.
gauze. What mean by alginated gauze? It's calcium alginate. What is this?
It's soaked calcium alginate, which is an extract from seaweed, which
We don't care to know what is
yes,
origin from, but
it
what is the
absorbs
value to put calcium?
absorbs the secretions of the wound.
No. What is the value to put calcium alginate in the wound? Is the hemostasis, because calcium is one of the clotting factor. All right. What else? You finish, cover and finish, or what?
I then cover the wound and finish, and I tell the patient about the instructions that he would need an antibiotic after that.
Okay.
Painkillers.
So, which antibiotic to give to him?
I would say
Fluoxetine, any cephalosporin, anything,
Yes.
no problem. But you missed something. You finish now.
yes, I would give the patient the other instructions and I finish.
What is other instruction?
About if any systemic symptoms like fever or
Okay,
any
what else?
swelling in the
Okay,
wound.
dressing, all this. Okay. Actually, okay, Dr. Abdurrahman, if you make this an exam, you 100% failed because it is against the guideline of any hospital in the world. Because
Yes.
the guideline of any abscess drained, you must, what you miss in the guideline?
Trimming of the wound.
No. You have drainage and abscess. What you missed? What is important step you missed it? Anyone?
Cutting
Culture.
the
Take a
loculi
culture
of
of the
the
pus.
abscess.
No. Okay.
Pus and
Culture and sensitivity.
curettage.
Okay,
yes.
so in the all over the world, is they have a policy for any perianal abscess, any abscess, you must take a sample for culture and sensitivity,
Yeah.
and this culture must be 2 samples, one for aerobic, one for anaerobic. We have a big achievement about that in perianal abscess. If you have perianal abscess and the bus is staph, other patient come to be E. coli. How to manage both? This is a question related to the station. If the patient have perianal abscess, one patient have staph, one patient have E. coli. How to manage? Okay. All right. So first, if the patient have staph, it is a skin infection. If patient have E. coli, can be perianal fistula. So we need to bring the patient again after 1 month to make examination under anesthesia. So back to the station again, abscess drainage. Abscess drainage, usually you have something like paste or toothpaste or whatever. So it is important after introduce yourself, looking for consent, prepare the equipment, skin preparation, make incision, irrigation by saline or betadine or hydrogen peroxide, send the sample of culture and sensitivity, but missed by all, put a bag, and this bag is bagged or soaked by betadine, which is bovidine iodine. Okay. If you make any drainage of abscess without sending a sample for culture and sensitivity, you will be in critical situation. In the thigh, we make it longitudinal to avoid injury of femoral artery, although it is deep, but will be referred in the thigh to be longitudinal, not transfers, not follow line of Rangram. Second station, usually you have, it is fine needle aspirated cytology, and usually you have the same bed, and they will put inside each cherry tomato. Okay, so we have something like cherry tomato, we put it here. Okay, suppose it is in the breast, but for exam, for the privacy of the patient, we make it in the thigh again. Okay, anyone have an idea? What shall we do? How to do fine needle? Suppose it is in the breast, so how to manage? Anyone need to answer?
Can I try?
Can. So Mariam, so if you have breast lump, in the exam we make it thigh, but make it breast, you consent to the patient, you explain to the patient, verbal consent, how to take a sample.
So for FNAC, I will inform the patient of the procedure I will be doing and confirm the side of the lump.
Okay.
And I will do FNAC under USG guidance if the lump is not big enough.
Under what?
Under USG guidance, ultrasound.
Okay,
guidance.
but this is superficial, no need, we don't have ultrasounds. What you will do?
If it is superficial, I will mobilize the lump between my fingers.
Okay,
And
of course you wear a gloves, not like this
yes,
patient.
with the glove. Yes, with the glove. Then I will make sure that the histopathology staff is around to examine the slide. I will mobilize the lump between two fingers and take a.
What needle you use?
So I will use 18 gauge needle.
Okay, so it is green or gray needle. Okay,
green or
it
gray.
is green needles. Okay, so
Yes,
it is also fine needle, but it is 18, so it is big size. What else? Of course,
Then,
you clean the wound and all this. After that?
Yes, then I will either use the plunger method or free aspiration capillary method. I can just puncture the maximum point of the swelling and just move it up and down, to and fro, until
So
I
how
get
many
blood
times you
aspiration.
need to enter the needles? 1, 2,
So
3, 4, 5?
I will get around 4 slides sample.
No, I mean that how many times you insert the needle?
Oh, up to and fro, you mean, Prof?
No exact number. Till the enough tissue is
Yes,
clear.
till the histopathology staff tells me that they have adequate tissue in the adequate cell count in the slides. Then I will clean the area with an alcohol swab and put a band-aid or a cover over the area.
Anyone need to add anything here?
I'll just add something in the abscess drainage. I have seen a lot of students for the abscess. In the abscess, some do cruciate incision, one longitudinal, one transverse. And then some do cutting the tip of the 4 quadrant. And some of them send the tip of the 4 quadrant for histology. And this is for an abscess, which is completely wrong. I would like...
No, actually... Prof, actually, it is correct in England for perianal fistula to exclude Crohn's disease.
That's true. But this is the one abscess in the side.
But I think they read it wrongly. Okay, so it is in the side, but suppose it is perianal abscess, and we know that the Crohn's disease is a common cause of perianal abscess in UK, so we're trimming the edges. This is why, even in Egypt, they're trimming the edge, but they don't send it for histopathology. But in England, they send it for
And I've seen one candidate which have done excision of an abscess, and he told me this way he will get rid of the abscess incision, and obviously he failed. So I would like you, Professor Sherene, to say you have maybe thousands of stations. You can say also the common mistake that you need to avoid. So this is a beautiful station, and fine aspiration cytology also the how many number is a very good question. Thank you.
All right. Okay, thank you. So I just finished fine needle. After that, we speak again. So in fine needle, thank you, Mariam. So explain the patient, use 10 milli syringe with green needle, which is 18 gauge. Of course, wear a glove. No need for local anesthesia. In some stations, you can use ultrasound, but not in exam. Prepare the skin first, palpate the swelling, hold it by left hand, and use the needle in different time till enough tissue come. Put aspirate in 2 slides, one fixed by alcohol. Of course, the slide also, you must put the patient name, so you must have the patient name. As you see here, this is a sample, and it is important to put a patient name on the slide. Okay? Thank you, Mariam, for this. So back again, procedure skill, usually it is one of the killer station in exam. I stop here because maybe have 10 minutes or something, but just to speak about our experience. Usually, a student, it is important to know we have a guideline, and this guideline is different from area to area. But at least to have fixed guideline, like if you drain an abscess, you must send for culture and sensitivity. And again, culture and sensitivity must be aerobic and anaerobic. The same for blood sample. If you have patient have fever, you send aerobic and anaerobic. I forget something very important also, and forget by Corollos and forget by Dr. Abdurrahman. So, Dr. Corollos, after you finish suturing, what you do for the needle and everything?
I will make it disposable in yellow bag or yellow box, asif, or safety box.
Yes. And the other in the so
The
it is
other in the
important
left
also.
bag.
This is have a mark in exam. So I just need to explain to you in suture techniques, whatever lacerated wound or excision of nevus or just a simple suture. We don't looking much to technique of suture because we know that some is senior, some junior, some expert, some not expert. But just to choose an instrument, how to prepare the area, what is the technique, but instruction before and after is very important. If lacerated wound, you need to ask about tetanus prophylaxis. What I give antibiotic. Usually in skin disease, I give cephalosporin or fluoxacillin or penicillin group or ampicillin group, whatever you need, at least to mention the name. If you ask you about the dose, I check in the drug index or BNF or application in the mobile. What I see usually, most of the student who is fail in this station or bad performance in this station don't test for the sensation first by use the forceps. This is the first mistake. Second, in lacerated wound, don't ask about tetanus prophylaxis. Third, he don't give instruction after that, instruction which is like where and when you remove the stitch. Again, it is important to know what happened in your country is not rubbish, is still good. It is policy, because when we ask about if the patient can take a shower or not a shower, in hot country, it is difficult to stay the patient 10 days, 15 days without taking a shower in hot weather like in Malaysia or Southeast Asia. So either you put opsite spray or either ask the patient to take a shower. So anyone, like for example, Dr. Coloros, if any of your patient after taking a shower have a complication?
No complication.
No, no complication. Okay, so it is important you don't have. I think your attitude, Dr. Corollos, is the attitude which is easy to fail. That you are. They need that. We expected that from the British examiner or the examiner. They need this answer. And again,
Yes.
You need to put in your mind, this is international exam. We run the exam by the same persons all over the world. I examine students in all the countries. I am examiner since 2007, so I examine thousands of the students, all nationality. So all nationality, each nationality have a different issue because different policy from country to country. But at least you follow the guideline in your country. Okay? Especially if you are examined in your country. All right. If you come to Malaysia or other country to be examined, usually, okay, you can just tell us what in your country, and you can compare.
Or you can take the safe option
All
of the
right.
answer. So taking shower every day is one of the nursing recommendation according to nursing guidelines in United Kingdom. So nothing, don't say in the exam,
Okay.
don't take shower. Showering daily,
Yeah.
even post-operative, is the routine. But how they do the shower away from the dressings, this is the tricky bit. So this is how to have a safe answer as well.
Yeah.
But thank you very much, Professor Sherene.
Yeah, it is not important in England because they are cold weather, so the patient is have no sweating and
Yeah.
other. But in Southeast Asia or Malaysia, it is we have temperature maybe higher than
Yeah.
Middle East. Okay. Apart from this is a station, anyone have a problem, Carlos? What you have else in the station in the skills apart from excision of nevus?
Castration, male castration.
Male castration. Okay. So how to put the local anesthesia in male castration? What you put?
I will put local anesthesia like gel inside the meatus of
What is the percentage?
venous. I don't know, but it was prepared on my station. It was already done, and
It is 5%,
I
usually 5% is the local gel. Okay.
okay.
All right. Is your station the urine come out or not?
No urine, and he gave me chart. I told him the patient is dehydrated. I should give him fluid, and I should consultation of.
Yeah. You try to irrigate it or not?
Yes, I try first irrigated. I make suprapubic pressure, but no urine.
Okay, all right. Usually in exam we put something mimic urine, so water and some yellow dye, no problem. Dr. Abdurrahman, you have abscess and what else?
Abscess and suturing.
Suturing, 3 suture. You cover
Yes.
the wound or not?
I don't remember really.
Okay, you test the sensation or not?
No, I didn't test sensation as in instructions. It told me that the patient is already anesthetized. So when I started, he began to
Yeah, in pain. You know,
complain.
this
Yes.
patient is well educated because you don't ask him, you don't test the sensation, so he mimic pain. So it is
Yes.
important.
I
to
didn't.
test
I
the
didn't ask
sensation.
him. I didn't try as in instructions. He told me he took the
Yeah, but you
anesthesia.
need to test it is working or not because it take about 5 minutes, maybe in some patient more. So you need to test it. Okay, this is usually one of the common mistakes because this is exam. This is a small mistake who makes some pass, some not pass, because it is difficult to pass all the student. Anyone have experience in surgical procedure? I think we maybe have 5 minutes or less. Dr. Yassin, are you entered the exam before?
No, sir.
Where are you from? Which country?
Sudan.
Sudan. Okay, you are welcome.
Welcome.
Okay, best wishes to Fawziya if you are from Khartoum. Okay.
Thank you.
You are from Khartoum?
Yes.
Yeah, you know her or not?
Yeah, I know her.
All right. I tried to contact her, but she not answered. No problem. Okay. Carmen, I think you are from Malaysia. Carmen, are you from Malaysia or from other country? I think they are muted or something like that. Anyone have experience about procedures?
Yeah, I just remember about the magnet. I will say very quickly. In the magnet station, you should tie the knot and keep your finger below the hook. And this is what you do in cystic artery, because if you pull both up, then you get avulsion. And because this round glass, this one, yes, it was very small, and we spoke to the Royal College, they actually got a larger module that you are able. This is the one which is the old module, which is very small and very tiny. Okay.